Hello everyone, my name is Matthias Volt. I'm a urologist from Basel, and I'm very thankful for the opportunity to present our work today. Here you can see our disclosures, including funding related to this work.
Spinal cord injury results in damage to descending autonomic pathways, causing a wide array of autonomic dysfunctions. Impaired autonomic regulation of the cardiovascular system is a particular concern as it increases the risk for adverse cardiovascular events in individuals with spinal cord injury. In able-bodied individuals, the sympathetic nervous system causes increases in heart rate and blood pressure. The heart is innervated by the sympathetic postganglionic nerve fibers from T1 to T6, while the gut and lower extremity blood vessels receive sympathetic input from T7 and below. Conversely, the parasympathetic nervous system plays the opposite role, reducing heart rate through the vagus nerve. Following cervical spinal cord injury, the heart and blood vessels to most of the body lose sympathetic control. This can result in abnormal blood pressure regulation and impaired cardiac function. In individuals with mid-thoracic injuries at T6 or below, the heart generally maintains autonomic function, but blood vessels below the injury lose sympathetic control, causing impaired hemodynamics. Bladder function is also impaired in individuals with spinal cord injury and can trigger adverse cardiovascular events. Autonomic dysreflexia is a potentially life-threatening condition characterized by an abrupt increase in systolic blood pressure due to noxious stimuli below the level of injury. Neurogenic Detrusor overactivity is the leading cause of AD events in individuals with spinal cord injury and requires routine neurodynamic studies for surveillance and management of lower urinary tract function. An example of this is shown on the right, where an individual with cervical spinal cord injury is undergoing a urodynamic study. During bladder filling, we can see an abrupt increase in systolic blood pressure followed by an episode of AD. Recently, our group published that intradetrusor Botox injections are effective at reducing AD events and severity during urodynamic studies in individuals with cervical and upper thoracic spinal cord injury. However, what is relatively less understood are the cardiac autonomic responses to bladder filling in this population, and if intradetrusor Botox injections also have an impact on these cardiac responses. Because there is little to no sympathetic activity to oppose vagal tone in individuals with cervical spinal cord injury, vagal activation during AD can cause several arrhythmic responses, such as severe bradycardia, atrioventricular node block, or even atrial fibrillation. An easy way to measure the extent of vagal activation at a given time is by spectral analysis of heart rate variability. Heart rate variability measures natural oscillations of beat-to-beat changes in heart rate. Heart rate variability in the high frequency measures changes between 1.5 and 4 Hertz that are generally mediated by the parasympathetic nervous system. Low frequency oscillations between 0.1 and 1.5 Hertz are a mixture of sympathetic and parasympathetic tone. In the present study, we use heart rate variability to assess cardiac autonomic responses to bladder filling during neurodynamic study in individuals with cervical and upper thoracic spinal cord injury. We then examined the effects of intradetrusor Botox injections on these responses. We took a subpopulation from our recent clinical trial to perform heart rate variability analysis during urodynamic study. Eligible participants underwent urodynamic studies at baseline and then 1 month post-intradetrusor Botox injections. Beat-by-beat blood pressure and ECG was recorded during each testing session and used to calculate heart rate variability. We also examined the relative responses in individuals with cervical versus age-matched individuals with thoracic spinal cord injury. As we can see in panel A, bladder filling prolonged RR interval, which is the inverse of heart rate, leading to transient bradycardia. The summary data in panel B showed that this bradycardic response was evident for the whole cohort, as well as those with cervical spinal cord injury. No change in RR interval was observed for individuals with thoracic spinal cord injury. Next, we examined the power spectral density curves to assess how cardiac autonomic signaling was changed during urodynamic study. Overall, low-frequency power was unchanged after filling. This is also true for the subset of cervical and thoracic spinal cord injury patients. However, consistent with the prolongation of RR interval, High frequency power was increased during filling in the whole cohort, as well as a subset of cervical spinal cord injury patients. Interestingly, there was no change in high frequency power during bladder filling in the thoracic spinal cord injury group. Next, we examined if intradetrusor Botox injections had any effect on cardiac autonomic tone during bladder filling. Botox injections effectively prevented the increase in RR interval during bladder filling and reduced the overall incidence of bradycardic events in the whole cohort, as can be seen in panels A and B. Spectral analysis of heart rate also showed the parasympathetically driven changes in high frequency power were also reduced. Finally, we aim to assess the change in RR interval or high frequency power were associated with the severity of AD experienced during the Neurogenic study. Interestingly, we observed that the change in vagally mediated high frequency power from baseline to filling was strongly correlated with maximum systolic blood pressure during autonomic dysreflexia. Collectively, these data show that bladder filling during neurodynamic study is associated with increased RR interval or a decrease in heart rate, as well as increased high frequency heart rate variability, which is suggestive of higher levels of vagal tone. Intradetrusor Botox injections significantly reduced this cardiovagal response to bladder filling, and that significant associations between heart rate variability and the extent of AD may suggest that heart rate variability could prove as a useful predictor of the severity of autonomic dysreflexia during neurodynamic studies.
And with that, I would like to conclude my presentation. Again, thank you, ICS, for allowing us to present our data. We're very thankful for the support from all the funding agencies. We have a preprint available for anyone who's more interested in the entire work, and feel free to send me an email. I'll be happy to answer your email. Thank you.